Hey class, so today in this huddle we are going to go over Class 2 composite fillings. The preparation that we're completing today will be a slot preparation on number 14. This is an example of a slot preparation on the mesial occlusal of number 3. For the slot prep, in preclinic, you will just break buccal and lingual contacts as well as gingival contact. No occlusal extension is necessary into the grooves. When completing a Class 2 preparation in preclinic, first visualize where the buccal and lingual contacts are. In this example, we are doing a full occlusal extension and extending to the buccal contact, as well as extending to the lingual contact. It is important to note that in preclinic, we are having you break both buccal and lingual contacts. However, when practicing on a patient, if the carious lesion does not extend to the buccal or lingual, you can keep those contacts intact. In this example, however, buccal and lingual allow passage of the explorer tip, and gingival contact is broken. You will always break gingival contact for convenience form. Now let's go over the different matrix systems we can use to complete a Class 2 composite restoration. This is the Garrison sectional matrix system, which has a separation ring, a pre-contoured sectional matrix band, which is the main advantage of using the system, and it still utilizes a wedge underneath the separator ring to provide a tight gingival seal. The Garrison matrix system provides reliable interproximal contacts. We can also utilize the Toffelmeier system, which we are familiar with from our Class 2 amalgam restorations. This system utilizes a full matrix band as well as a wedge and relies on wedging as well as very good burnishing in order to provide reliable interproximal contacts. The Toffelmeier system is a great system to use when your Class 2 composite preparation extends past a line angle on the facial or lingual of the tooth. Now let's go over this carious lesion seen on the distal of number 13. In preclinic, we tell you to have an axial wall depth ideally of 1.0 to 1.25 millimeters, extending up to 1.5 millimeters for acceptable. You can see that even at 1.5 millimeters, we have not removed the full extent of this carious lesion, and I'm circling that right now for you. So always remember that when practicing on patients, the depth of your axial wall will be determined by the extent of the carious lesion. In this example, we will have a very deep axial wall. If the carious lesion is not as far extended, your axial wall may not be as extended. However, you always need to extend your axial wall deep enough to provide convenience form. As we see with this carious lesion, it is a very deep lesion. Ideally, you would have a discussion with your patient prior to beginning that there is a possibility of pulp exposure during preparation. In the example provided in the huddle, the patient was asymptomatic on the tooth, and you endotested it prior to providing anesthetic, and it tested as vital. However, during preparation, you still did have a pinpoint pulp exposure. With a pinpoint pulp exposure, the prognosis is best if the tooth is vital, as well as testing asymptomatic prior to the exposure. However, we will now go over how you will manage this in the clinics at UIC. When you have a pinpoint exposure, you will first place a calcium hydroxide layer over the exposure. In clinics at UIC, you will use DiCal. The calcium hydroxide will stimulate the formation of dentin bridges, and this is highlighted in green on our picture. Next, you will place a layer of RMGI. In clinics at UIC, you will use Fuji Lining LC. over the calcium hydroxide that is in yellow. You will then place your composite restoration over your direct pulp cap. Post-operatively, you will inform your patient of the symptoms of reversible and irreversible pulpitis and tell them that if irreversible symptoms occur, root canal therapy will be necessary. That concludes our huddle for our Class 2 composite filling. Please come to clinic prepared, and we look forward to seeing you then.